So when it comes to the cervical screening care pathways are similar. Don't get confused. If people say that there is a 2026 guideline which is out, there is no guideline which is out as such. The pathway would remain the same. Okay, the pathways, the flow charts which you were studying from your 2025 guideline, that has remained the same. There are only few things that has been added in your 2026 that has been added to the program. Okay, the way it used to function, like the routine screening, we used to do it like for every 3 years, but now anyone with a cervix between the age of 25 to 64 years is routinely invited for screening every 5 years. So this has been changed from 3 years to 5 years. That is one update you guys should be having. The routine recall is always 5 years. Okay. And we have introduced the HPV self-sampling as well. So we are going to post them, all these materials that is important for collection. So who has never attended the screening or who are at least 6 months overdue for their appointment, they generally get the letters. Okay. Whoever is living in the UK, they get the letters for the NHS cervical screening appointments. And if they have not responded, if they have not booked any appointment with a GP and it's been 6 months overdue for their appointment, or they have never attended the screening, then we can go for this HPV self-sampling. Home kits are available. This is the only program update. But when it comes to the cervical screening care pathway, you can study the 2025 guidelines. Okay, clear everybody?
Yes, ma'am. Yes.
Okay, perfect. So we are going to have some brainstorming activity now. So we have got only three flow charts, which you guys are supposed to go through when it comes to an exam. So do it like, every week you try to revise these things. Don't keep it in the end, okay? Because this is something, it's something like a calculation. It's like a permutation and combination. You guys have to remember it all the times. Don't do it like just before the exam. So try to practice it, whenever you're studying with your a role player, I mean the study buddy, just in the last 5 to 10 minutes when you're taking a break or something, just ask them few questions that if this is the scenario, how you're going to go about it. If this and this is there, how you're going to go about it. So try to do this, even if with yourself, when you go to the bed, before you take a nap or something, try to do that in your mind itself, that it becomes very, very easy rather than sitting with those flowcharts. It's extremely difficult to remember, and it is very short lasting memory. So you may do it, but the next day, after a week, you may forget it. So try to do them on a repeated note. Okay. So the questions we will answer today out of this webinar is that, there's so many questions. If high risk HPV test positive comes positive, what are we going to do next? If high risk HPV test comes positive but cytology is negative, how we are going to do this? Who will come under 2 weeks pathway? Who will come under 6 weeks pathway? What is this test of cure? What is the cystic glandular intraepithelial neoplasia? What if it is completely excised? What if it is incompletely excised? These are the common scenarios which are being tested in your both part 2 and part 3 MRCOG exams that you should be knowing. So we will start this with some of the activities that how we generally do it, so that it is not boring and everybody will understand it. Okay. So what is the target population for the NHS cervical screening program? We just discussed that in the beginning. What is the age group? What is the age population for whom we are doing the screening program?
25, 64 years.
Yeah, 25 to 64 years of age is like, women and people with a cervix. Few trans men also will be having the cervix. So they also come under that cervical screening program. So between 25 to 64 years of age. So anybody you are meeting after 64 years of age, you can ask them whether they were up to date with the smears and whether they're normal, up to 65 years or 64 years of age or not in the exam. So the first invitation is being sent to all the eligible people at the age of 24 and a half years. Okay. And then they'll start attending the cervical screening 25 years. And it's normal. Then they go back to the routine recall. And the routine recall is not 3 years anymore. It is 5 years. Okay. So the next one, if they have done it at 25, then the next one they get it at 30 years of age group. So we'll do some scenarios here to understand the situation better. Suppose a woman, say for example, Laura has done her HPV test results and the HPV test results has come back as unavailable. Okay. Or cervical sample is reported as inadequate. at any stage of the NHS, the cervical screening program for that. So what are you going to do now? If you see the word HPV test result is unavailable or cervical sample is inadequate, so what are you going to do?
To be repeated?
Repeat it? Yes. So we are going to repeat it. And whenever you're repeating it, not less than 3 months. Okay, at least 3 months and above. So the sample has to be repeated after a minimal interval of 3 months. Okay, whenever you see the results unavailable or inadequate, we're simply going to repeat it after 3 months. Suppose it is second consecutive unavailable or inadequate results. So you've done the HPV test results, it was unavailable, inadequate. You called her back after 3 months, and again the results are similar. Okay, it is consecutively unavailable or inadequate. Then direct referral to the colposcopy because we don't know what's going on. I cannot assume that HPV test is positive, negative, the cytology is low grade, high grade, borderline. So we cannot assume anything in here. So they will go directly, to the colposcopy. Understood? So two consecutive unavailable or inadequate cervical screening results, refer to the colposcopy. Nazia, what do you want me to repeat it, dear?
Ma'am, it was the answer of a previous question, like need to repeat it inadequate. That's right.
Okay, perfect. So
Thank you, ma'am.
now, scenario 2 anybody can take this. High risk HPV test has come negative. Okay, she has come for the routine cervical screening. HPV test is negative. So, do you need the cytology?
No.
So, we always use the cytology to triage it. It is also called as a reflex test. So, do we need a cytology? The answer is no. So, when the HPV test is negative, we don't expect any cells to be abnormal. We don't expect any changes to happen within the cells. So, no cytology is required and it's a routine recall. What is the screening interval now, according to 2026?
5 years.
Yes, so we have to do it in the routine recall in 5 years. So HPV negative, she doesn't require any further testing in the form of a cytology. So if the high risk HPV test is positive, so what next?
We will do cytology.
Yes.
Yes.
So whenever the high risk HPV is positive, we expect some cell changes to happen. So we do the reflex cytology. The cytology is negative. Okay, high risk HPV test is positive and cytology is negative. So what are we going to do now?
We will repeat it after
Repeat
HPV
it.
test. 12 months. 12 months.
12 months. What is the reason behind it?
Because already there is a positive, we have to just confirm that again it is a positive or negative. If it is a negative, then we will go through the routine screening. If it is again positive, then we will go for the cytology. And
Yeah.
again, depend
So
on
the
result.
reason why we repeat it in 12 months is that we expect the HPV to get cleared from our body at least in 12 months to 24 months. So we give them the first screening after 12 months. Okay. The reason means many HPV infections they clear spontaneously in these 12 months of time. So just to making sure that whether it is positive, negative, as you told, we're going to repeat it in 12 months of time. Everybody is with me so far? Yes?
Yes, ma'am.
Okay. So now she has come back because the high risk HPV test was positive and the cytology was negative, and you told her that okay, we expect the HPV to get cleared from our body within 12 months to 24 months. You come back after 12 months and she has come back now. So 12 months review after the high risk HPV has come negative. Okay. So what next?
Routine call?
Which is?
Routine recall.
Routine.
Yeah, which
Yeah.
is?
5 years.
5 years, yes. So routine recall in 5 years of time. So the same lady at 12 months, unfortunately, it has come positive again at 12 months. So what are you going to do now?
Colposcopy.
Cytology.
Sorry?
Colposcopy.
Cytology.
Okay, one person is saying cytology, the other person is saying colposcopy. What should we do? Anyone else?
Cytology.
Cytology.
Yes. So whenever you have got HPV test positive at 12 months, do the cytology. And if cytology is abnormal, then colposcopy. So remember, anytime cytology is abnormal, be it a low grade, high grade, borderline, please refer them to the colposcopy. Do not assume just because she has got borderline or a low grade, it could be normal. Okay, we should see it on the colposcopy and then only we have to reassure because it could be an occult condition. So always remember that HPV positive at 12 months, perform the cytology, and then if the cytology is abnormal, refer them to the colposcopy. Cytology is negative. So then what are we going to do next? So she's at 12 months follow-up. You have done the high-risk HPV, which has come positive. Cytology is negative. So what are you going to do next?
Again, we are going to repeat HPV at 12 months.
Yes. So we are going to repeat them in 12 months. So total, we are giving her 24 months, expecting that HPV would get cleared in 24 months of time. Okay. So 12 plus 12 months, total 24 months we are going to offer her to come back because the cytology is anyways negative. So we don't require any colposcopy at this point of time. Understood, everybody?
Yes, ma'am.
Perfect. Now she has come at 24 months because she had that high-risk HPV, which was positive. And high-risk HPV test remains positive for the third consecutive time. 12 months she had come, 24 months she had come, and it is still the third time it is positive. So, yes.
Colposcopy.
So colposcopy. Remember, now we are going to do the cytology for sure. Okay. But regardless of the cytology results, we are referring her to the colposcopy because it's a persistent HPV. Remember, at 12 months, we don't say it as persistent. But at 24 months, that is 2 consecutive HPV tests have come positive, which is called persistent HPV. We expected it to clear in 24 months. It has not happened. So she will be under high risk. She will be coming under high risk. So we need to investigate and we have to refer her to the colposcopy. Clear?
Yes, ma'am.
Okay. So now high risk HPV is positive. What next? We do the cytology. And high-risk HPV test has come positive. We do the reflex cervical cytology, and that has come abnormal. Okay, this I'm not talking about. This is in general. Okay, you have done the high risk. This is the first time you're talking about. High-risk HPV test has come positive, and you have done the cytology, and it has come as abnormal. So what are you going to do?
Colposcopy.
Yes, direct referral to the colposcopy. At any point of time you see the cervical cytology is abnormal, be it low grade, high grade, borderline, you are going to do the colposcopy. So the one memory rule you guys have to remember is that whenever it is negative, in the anywhere you see the HPV negative, it is going to be a routine recall. This I'm not talking about post colposcopy. This is pre colposcopy. She's just getting the screening done, routine screening done. We have not done any colposcopy, no biopsy, nothing. Then if the high risk HPV is negative, then it's a routine recall, which is 5 years. Wherever you see the high risk HPV test which is positive, then always do the cytology. If normal cytology, then ask her to come back in 12 months of time. But it is abnormal cytology, do the colposcopy. And if it's a persistent high risk HPV, even after 24 months, then you have to do the colposcopy. Clear up till now? This is all before the colposcopy I'm talking about. Clear?
Yes, ma'am.
Yes.
Perfect. So this is what we were talking all these while. This is the flow chart number 1 you guys have to go through, the sample taking and HPV testing and the cytology triage. So this we have already discussed, but if you want me to go through this quickly, I can just quickly say this to you guys. So yeah, so we carry out the HPV and then we are going to we see whether it is HPV negative. So negative nothing, it is a routine recall which is like 5 years now, and this is for all the age group. Generally we do it for 5 years, and then if it is positive, then do the cytology and look at the cytology whether it is negative or abnormal. If it is abnormal, then she comes directly to the colposcopy. But if it is negative, call her in 12 months of time. and look at the HPV again, whether it is positive, negative. If it is positive, again do the cytology, and looking at that, if cytology is normal, again she goes for the colposcopy. So this is how it works. So the simple funda is the same thing, that we give the HPV some time to regress up to 24 months. So, but we call them every 12 months, 12 months. If it is persisting, then you refer them to the colposcopy. But any point of time you see the cytology which is being abnormal, refer them to the colposcopy. Once the HPV test is negative before the colposcope, then you don't have to worry about it. You call them routine recall in 5 years of time. So this is the one chart you guys have to remember it like this. Okay. And moving on with colposcopy management scenario. So this is the next thing which we are going to take. So the first step when they have speaking about the colposcopy in the scenarios, be it a part 2 and part 3 MRCOG, the first step is to assess, to see, look out for the words. Are they talking about the colposcopy as adequate or inadequate? You don't have to worry about adequate, inadequate, how it looks. Generally, they say it as adequate, or they may say entire ectocervix is seen, entire squamocolumnar junction is seen, or transformation zone is seen. When it is not visualized properly, when endocervical canal is not seen entirely, then it is inadequate. We have to see everything, ectocervix, endocervix, the squamocolumnar junction, the transformation zone, then only it becomes adequate. Okay, so this is the first step you guys have to watch out for in your scenarios, whether they are saying. So before you even interpret the results, this is the first thing you have to see, in your scenarios. So now the scenario number 1, colposcopy is inadequate. Let's take the scenarios of colposcopy being inadequate. So when they say colposcopy is inadequate, look at the reason for which the patient was referred to the colposcopy. Okay. Obviously, high-risk HPV test will be positive and they would have done the cytology. So look at the cytology results. Are they saying low grade, high grade? What exactly is it? Low grade means it could be ascus cells, which is atypical squamous cells of uncertain significance, squamous. Or they may give it as LCIL, or they may give it as borderline squamous. I'm not talking about endocervical, not borderline endocervical. I'm talking about borderline squamous. Squamous is still okay for us. It's low grade. So look at that. Sometimes they give it as a low grade. Sometimes they give it as like this, ascus or LCIL or a borderline squamous. Okay, understood? So in this scenario, can you discharge her from the follow-up? She was high-risk HPV test positive and the cytology showed low-grade cells and the colposcopy is inadequate. So how are you going to counsel her?
Another 1 year.
In 1 year,
We'll
what should we
recall
do?
her and we'll recall an HPV again.
So we have to repeat the colposcopy. Remember that. It's not the
Yes.
high-risk HPV test we are going to repeat. We want to repeat the colposcopy. This is all the colposcopy-based scenario. They are giving colposcopy inadequate. So we could not see everything clearly, but then it was a low grade. Okay, it was not a high grade required a biopsy. It was a low grade. I can still reassure the patient that it's a low grade. And since we cannot see the colposcopy entirely, we cannot see all the zones of the neck of the womb entirely, we have to repeat your colposcopy in 12 months of time. Understood? Everybody?
Yes, ma'am.
Yes.
So Nasia, persistent is 3 positive HPV. So of course, that is the first time she had high risk HPV test positive. So you asked her to come in 12 months of time because the cytology was negative. And the second time also it was positive. And then you asked her to come after 12 months, which is 24 months. That time also it is positive, but cytology is negative. So yes, that becomes 3 persistent. That's how it works. Okay, but 2 consecutive is what we told for when it is like inadequate, sample is inadequate, or we don't have when it is unknown, that is 2 consecutive. But here the persistent HPV is, of course, it has to be 3 times it is positive. Yes. So this is what you have to look at it. If they've given you the colposcopy results, colposcopy adequate, inadequate. If it is inadequate, look at the cytology results. So cytology results is low grade or high grade. If it is low grade, but you could not see the colposcopy entirely, do not discharge her from the follow-up. She has to come back in 12 months of time for the colposcopy. Clear, everybody?
Yes, ma'am.
Okay. So now the colposcopy is inadequate, the similar scenario, and you looked at what is the reason for which she has been referred, and the cytology is high grade. Okay. What is high grade? Either they give it as HEDSIL or they may give it as borderline endocervical or glandular pathology. Remember, this is very, very important. This is how they confuse you guys. Either they give it as borderline squamous or they give it as borderline endocervical or glandular.
Mm.
So if it is squamous, squamous is good, thumbs up. But endocervical or a glandular pathology is not low grade, it is high grade. These are the only two differences you guys have to remember. So can you discharge her from the follow-up now?
No, ma'am, I
No.
think this requires excisional treatment.
Yes, she requires a diagnostic excisional treatment in the form of LETS procedure because I could not see properly the transformation zone. I could not see the endocervical canal. So I cannot reassure the patient and send her back. So we have to have a LETS procedure done for her because it is a high grade. Either it is a HEDSIL or a borderline endocervical. Understood? This is all the logics. This is very easy now if you guys think this way. Okay, that why we can discharge her, why we can't discharge her. Any questions so far? Clear?
Yes.
Yes.
Perfect. So now that is a scenario you would have generally. The colposcopy inadequate, look at that what type of cytology, there's a low grade or high grade. These are the only two scenarios that you have to remember from the colposcopy inadequate. Now the colposcopy is adequate. Same strategy here also. Look at the cytology. And the cytology is low grade. Either it is ascus, LCIL or a borderline squamous. So what are you going to do now? Adequate. Colposcopy is adequate. Colposcopy is normal. You did not see any CIN, nothing on the colposcopy. So what will you do?
Discharge her.
Discharge her and then
Recall.
is it a
Routine recall.
recall? Is it a routine recall or is it a recall in some years?
1 year, as it's high risk.
Why
I
high
think
risk?
I think 3 years, ma'am. 3 years, 36 months around.
1 second.
Yeah.
Hamada, you are right, dear. Hamada, why 1 year?
High risk virus.
High risk HPV positive is something that is there. That is something, it's like a first test that has led to your triaging of cytology, but we are looking at the cytology. What we see under the microscope, that's important for us to decide. So it's a low grade, no? They have seen it. They have done the cervical cytology and it is low grade and you could see the colposcopy clearly and it's adequate, it is normal, there is no CIN. So how are you gonna, why do you want to call her in 12 months of time, dear? It's a low risk and it's a reassuring colposcopy. It's not inadequate. If it was inadequate, like see, we did this one, right? Yeah, sorry. Yeah, see here, colposcopy was inadequate. Okay, that means we could not see everything clearly here. We could not see the transformation zone, endocervical canal, nothing. We can't be reassured that everything was fine here. And the cytology was low grade. So here you call her back in 12 months of time for the colposcopy because we could not see everything on the colposcopy properly. But this scenario, what I told you is that colposcopy was, everything was fine. It was adequate. We could see everything. There was no CIN. So she comes at a low risk, isn't it, Hamada?
Okay.
So we recall her in 36 months of time, which is 3 years. Remember, it is not a routine recall. Your routine recall only comes before a woman is being subjected to the colposcopy. That is what is the discharge and a routine recall, which is 5 years. But once a woman undergoes colposcopy, nowhere you get it for 5 years. It's always a routine recall in 36 months of time. Okay? Understood? Any confusion? Please ask at this point of time.
Yes, ma'am, this point is clear now. Earlier, I was thinking that here we need to just, like, keep the patient on routine recall that is around 5 years, but now you
No,
have given
it is
after 4
36 months. Yes.
months,
Okay.
after
That's
4
yeah,
months.
that's the paradox you guys have to remember. Yes.
Yeah.
So now the similar scenario where the colposcopy is adequate. It's normal. We could see everything nice and fine. On the background, she has been referred for cytology being high grade. So how are you going to go about it? No thoughts?
What is disciplinary meeting?
See, when the colposcope was inadequate and when it was high grade, you did a LEDS procedure because we could not see anything properly there. So how we are gonna here the colposcopy is adequate, normal. They could not see anything abnormal there, but cytology is showing high grade. How we are gonna convince the patient now?
I think again,
Multidisciplinary meeting.
Yes. She requires an MDT meeting. This case has to be discussed in MDT. Should I be worried? Why I'm discussing this with MDT? Any particular reason?
There is a
Discrepancy. Yes.
discrepancy.
Perfect. So we are seeing that on the cytology that the test is high grade and we could see all the zones properly. We could see the transformation zone, endocervical canal, ectocervic, everything. However, there is no abnormality. How is it possible? I wanted something to be there, either CIN 1, 2, 3. So there is a discrepancy in the results. So I am worried. So discuss this with the MDT and consider doing LETs for her. Okay, remember this. This is the commonest scenario you would get. Colposcopy is adequate. It is normal. On the background, she has got a high grade cytology. There is a discrepancy. I expected some abnormality to be seen on the colposcopy, which is not there. So due to this discrepancy, I would discuss this case at MDT within 2 months of time, considering doing a LETS procedure for her because high grade cytology, despite normal cytoscopy, as colposcopy, it's a concern for occult disease. We might be missing it. Okay?
yes,
Yeah? Everybody? Yes or no?
yes, ma'am.
Okay. So this is what I was talking about. So now I'll just quickly go through this again. So when we do the colposcopy examination, how we are going to do the results or the interpretation out of it. So first step is always look at the colposcopy is adequate or not. If it is not, then you look at the results of your high risk HPV. I mean, for basically for what reason they were being referred for the colposcopy. If it is low grade, that means it is ascus cells or L cell or borderline squamous, then repeat the colposcopy in 12 months of time. Do not discharge them because we could not see the colposcopy clearly. So we call them in 12 months of time for colposcopy. But if you have done it, but on the background it was high grade or borderline endocervical or glandular, then do the LETS procedure there. But the colposcopy was satisfactorily adequate, okay? But it was normal. There was no CIN, nothing. Then you see whether it is done for the low grade or whether it is done for the high grade. If it is done for the low grade, I mean, basically the cytology was low grade, then you recall in 36 months. They'll not go discharged and go back to the routine recall in 36 months of time. But high risk HPV was positive and the cytology was high grade and above or borderline endocervical. But colposcopy is appearing normal. How is it possible? We expected some change to happen. That is not showing. So discuss this case with MDT in 2 months of time and then consider LETS procedure to rule out occult disease then. So anytime you can see the abnormal, yes, of course, you're going to do the LETS procedure. That is not something you guys have to remember. Understood? This is the second flowchart you guys have to remember. So do it like this, how I'm giving you the scenarios. Do it like that. It will be very, very easy for you guys. Okay, clear?
Yes, ma'am.
Perfect. So now moving on with the next scenarios. So always adequate colposcopy, but it is showing CIN 1. Okay, we are not talking about the normal colposcopy now. Adequate colposcopy, and it is showing CIN 1 as a colposcopic impression of CIN 1 based on what they see, the patterns and everything, or the biopsy has, proved it as CIN 1. So you will manage this as CIN 1, and remember CIN 1 is always conservative. So she would require a follow-up. So we will call them in 12 months of time. Since she has already underwent a colposcopy, we are not going to call them for colposcopy once again. We call them for the repeat high-risk HPV testing and cytology in 12 months of time. Understood? CIN 1, the follow-up is in next 12 months of time. We try to manage it conservatively. So ask them to come back in 12 months of time. So if at all you get a scenario that she had a high-risk HPV positive and cytology was abnormal, and you referred them to the colposcopy and the colposcopy showed it is a CIN1. So the follow-up plan will be for her, come back in 12 months of time. We are going to repeat the test of high-risk HPV as well as cytology. And anytime the cytology is abnormal, HPV test is positive, again, she will be referred to the colposcopy. Okay? Clear?
Yes,
Everybody?
clear.
Yes.
Okay. So now adequate colposcopy, but there is no CIN. Nothing. Everything is normal. But she had 2 consecutive high-risk HPV positive results, or high-risk HPV test positive was inadequate. Again, you call them back in 12 months of time because we want to make sure that everything is nicely cleared or not. So this is another flowchart. This is the third flowchart you guys have to go through. So this we have already discussed that if there is a CIN1, then we recall them in 12 months of time. Okay. And if high risk HPV is positive or negative, if it is negative, then recall in 36 months of. So they are never going back to the routine recall, which is 5 years. You guys have to remember that. Okay. Everybody? So do not say routine recall. It's always recall in 36 months of time post, colposcopy. So if it is CIN2 and CIN3, what are we going to do? Anyone wants to volunteer? Basma? Yeah,
Recall
yeah,
is-
yeah, go on. Go on, dear.
We
If it is
get treatment.
CIN2 and CIN3, what are we going to do?
We get treatment with LLED set.
That we have already treated, no? We had a LEDS procedure. This is the LEDS procedure I'm talking about. The LEDS procedure has given you the results of CIN2, CIN3. Okay? So now,
Repeat HPV.
yeah, in
6 months.
yes. So now we had an abnormal colposcopy results. We have done the biopsy. So either it is a CIN2 or CIN3, or it could be cystic glandular intraepithelial neoplasia. If it is CIN2 or CIN3, we are going to offer her the test of cure. That is to make sure that whatever the biopsy, whatever the margins that we took out is negative for HPV, as simple as that. So we are going to have a test of cure in here. And the first the test of cure will be in 6 months of time. Okay, so you can see here that it is CIN2 or CIN3. So provide treatment and recall in 6 months of time. And if it is still positive or negative, you see. If it is negative, then recall in 36 months of time. But if it is positive and cytology is either negative, inadequate, abnormal, she will directly go for colposcopy, maybe because the treatment that we have done may not be sufficient to clear the HPV. So always remember, for CIN2 and CIN3, there's only one test of cure, which is in 6 months of time. Clear? But if they say it is cystic glandular intraepithelial neoplasia, then how is it different from CIN2 and CIN3? If it is cystic glandular intraepithelial neoplasia.
Yes. After, I think, ma'am, let's procedure, we will call her back at 6 months, and then again,
If it is
and
negative, then we have to have a second test of cure, which is in 12 months of time from the previous. So you have to understand, for the part 2 people especially, they have to remember, they may confuse. So it is 6 and 12 months, 12 months from the previous result, or it is 18 months from the time of procedure. Okay, so we are going to do the 6 months. If it is negative, then we are going to get one more test of cure in 12 months of time. So they will have total 18 months follow up. And after that, if it is negative, then they go back to the recall in 3 months, 3 years, which is not a routine recall, but it's recall in 36 months of which. Okay, understood? So these are the 3 scenarios you have to remember. CIN 1, so then we have to call them in 12 months of time. CIN 2 and 3, we have to call them in 6 months of time to achieve that one test of cure. If it is cystic glandular intraepithelial neoplasia, then we call them at 6 months. If it is, that's the first test of cure. If it is negative, then we are going to call them for the second test of cure, which is 12 months from the previous HPV testing. Clear? Yes, the test of cure is always the HPV testing here. Correct, Dr. Zeeb. Okay, clear, everybody?
yes,
Clear?
ma'am.
Okay. So this you understood, but if you go through the pathway, there are something that they have mentioned here. It is a bit confusing, so I thought I will explain this to you guys, what it means to you, because this is not given in this flow chart, or this is not given in this pathway. You have to go back and check, I think, the different article for this. So I will explain what exactly it means to you guys. So suppose they have given cystic glandular intraepithelial neoplasia, which you understood. Okay, that she underwent a colposcopy, and the colposcopy results turned out to be it's a CGIN, and she has undergone a LETS procedure, both diagnostic and therapeutic excisional biopsy. And we have called them for the test of cure at 6 months, and it is negative. Then again, you call them back in 12 months or 18 months from the time she underwent the procedure. And if it is negative, then the discharge to the 3 years a recall. And then we continue to do the routine screening for them will be 3 years. So they no longer become 5 years. So for them, the routine recall becomes every 3 years. At any point during this next 10 years, if the high-risk HPV test becomes positive, they go back to the colposcopy. We don't even care about the cytology here, because these are the people who underwent the LETS procedure. So we don't really worry about the cytology results. They go back to the colposcopy. But the another scenario that you may get in the exam is incompletely excised or positive margins. She had some high risk HPV test positive. She had some cytology abnormality. She underwent a colposcopy, and colposcopy showed some cystic glandular intraepithelial neoplasia. And now she has come back with the results. Okay. And the results says you have to like talk to her about the follow up. But the result says it's incompletely excised. If it is completely excised, 2 test of cure, simple. 6 and 12 months. Yes, but now they're saying it's incompletely excised, and how we are going to, guide her about the follow-up. Anyone? Yes? You can read the slide and tell me otherwise. So when we have the incompletely excised or the positive margins, we cannot safely tell her to come in 6 months and the 12-month, that is 2 test of cure, because we need to really, really exclude occult invasion. It's very, very important to achieve the clear margin. So if possible, try to do the repeat excision for her. Tell her that we may have to do a one more LETS procedure for her, try to achieve that margins, clear margins. If that's not possible, then she can come back in 6 months, and then 12 months, and then annually for next 9 years. Total 10 years of surveillance, be it for a completely excised CGIN or an incompletely excised CGIN. It's a 10 years of surveillance, but they were coming under 3 years recall. But these people, if you if she's agreeing, and if you can go ahead and do the repeat excision, do it to achieve that complete clear margins. If that's not possible, 6 and 12 would remain the same. That is, test of care would remain the same. But after that, once at 12 months it is negative, the high risk HPV test is negative, she will not go back to that recall of 3 years, but she has to be under annual follow-up for next 9 years. Okay, any time in these 9 years, if the HPV test becomes positive, we are going to do the colposcopy irrespective of the cytology, because the cystic glandular intraepithelial neoplasia is more invasive. It tend to have more occult invasion, so more rigid follow-up is really, really required than completely excised CTIN. Okay, any question? Understood? Can someone repeat this for me? Yes? Come on, guys. Nobody wants to say? That means nobody has understood it. Dr. Hamada? So if it's incompletely excised, what are you gonna do?
We will do re-excision, ma'am.
Yeah. If she's not
We will
agreeing, or it's
then that
impossible. Yeah.
yeah, we will do the at 6 months or at 12 month
6 and 12
test.
would remain the same. It's just that she will not go back to the recall of 3 months, right?
Yes,
So
yes,
annual follow-up for next 9 years. Okay?
yes, yes.
Perfect. So always remember, the cystic glandular intraepithelial neoplasia is treated differently from the CIN, because it can extend up to the endocervical canal, because already the glandular cells are abnormal, and they are dividing rapidly, and they tend to have the skip lesions as well. It's very hard to visualize colposcopically, and it has a higher risk of residual disease. Even if you have taken the diagnostic or therapeutic excisional biopsies, you must have missed, and some residual disease is very common. So the clear margins, achieving the clear margins is very, very important. So unless you see that word like clear margins, don't discuss like test of cure of 6 and 12, and then after that it's a recall of 3 years. If it's incompletely excised, please offer them the re-excision if it's possible. If it is impossible, then yes, she has to do the 6 and 12 and then annually for next 9 years. And MDT discussion is very, very important for every cystic glandular intraepithelial neoplasia cases. Okay. So this is something that we have already discussed. And another question that you guys, yeah, it's like that. So another important, I see this a lot of times in our, in our classes, that they try to unnecessarily mention this waiting pathways. But if you guys are sure about the waiting pathways, you mention it. But if you don't remember it, you don't have to bother about it. Sometimes the role players might ask this question, that how long I have to wait for this procedure to get it done, or when will I be referred to the colposcopy, because you're seeing her somewhere in the gynae clinic, or or in the GP clinic. So they want to understand that when they will get their appointments for the colposcopy. So you guys have to forget about the 18 weeks pathway. For your exam, just remember 2 weeks wait pathway, 6 weeks routine colposcopy pathway. So whichever is like uh, for you, if you just listen to that word, which says abnormal, they all come under 2 weeks wait pathway. Invasion for sure. If you're suspecting an invasion out of cytology itself, definitely she will go for the colposcopy. High grade dyskaryosis. You see, there is a moderate and severe high grade cells on your cytology. Definitely, she goes for 2 weeks wait pathway, which is a cancer pathway. If you see glandular neoplasia, which is CGIN, of course, she will go for 2 weeks wait pathway. If you see borderline endocervical, okay, then also she goes for 2 weeks wait pathway. But rest other, like low grade, borderline squamous, persistent high-risk HPV positive, persistent inadequate samples, all these will have to wait for 6 weeks. After that, they get their, colposcopy appointment. Okay, so whichever feels very high grade, glandular neoplasia, borderline endocervical, all these will go for cancer pathway. So this is also the common mistakes you guys generally do it. So remember that. Otherwise, your low grade, persistent HPV, borderline squamous, persistent inadequate samples will not go for the 2 weeks or a cancer pathway. Clear? Upon this the concept of cancer waiting times, the national policy?
Yes, ma'am.
Okay. So somebody who
ma'am.
underwent a simple hysterectomy, so this is also sometimes in the recalls which is being asked, is out of nowhere, that do I need to continue the cervical screening program? So that was a question which was asked by the role player. She underwent simple hysterectomy for some reason, okay, some benign gynae pathology like fibroids or something like that. So we don't do the Walt smears or Walt cytology routinely. We do it for a purpose. So say for example, women who have had a total hysterectomy, like the cervix is out, okay, then she doesn't have to do the routine cervical screening because she doesn't have the cervix anymore. So she doesn't have to do any Walt smears, nothing. The only reason we do the Walt samples is because of previous history of CIN. So it's very, very important to understand for what reason she underwent hysterectomy. Was it other benign pathologies? And what was her cervical smears? This is the question that you always ask in the stations, like, okay, before your hysterectomy, whether your cervical smears were normal, negative, things like that. It has a reason that why do we ask that, because in the follow-up you have to mention about some Walt smears. So if she said my cervical smears were negative, they were all normal before my hysterectomy, so you don't have to suggest any cervical screening program for her. So she doesn't require any Walt smears. But if she had any previous history of CIN, she underwent treatment for that, or she was under follow-up or something, then you would require a Walt smear. So hysterectomy for some reason, but her cervical smears were all normal, so no Walt smear. You discharge her from the cervical screening program. And if they say, yes, I had a CIN, then you have to look into, is it a completely excised CIN, be it a 1, 2, 3, whatsoever it is. If it is completely excised CIN, then just do one Walt smear in 6 months of time, just one test of care we require. And at 6 months, it is negative, discharge. But if it is positive, then you do the colposcopy, similar way. Incompletely excised CIN1, then the Walt samples has to be taken at 6 months, 12 months, 24 months. If it is incompletely excised 2 and 3, then 6 months, 12 months, and again annually for 9 years. If it is a subtotal hysterectomy, obviously there is a cervix, so she has to continue with a routine cervical screening program. If it is radical trachelectomy, then she would require a specialist follow, but not routinely we do the screening program for her. So this is something that you guys have to remember as well. But don't remember this now. First, try to remember all the basic things that we have discussed first. Once you master over those things, then you can remember this part in addition to it. Otherwise, if you remember everything all together, then there is a high possibility that you may mix up things. So first, whatever the 3 flowcharts which I showed, first is that before the colposcopy, which is doing a high-risk HPV testing, reflex cytology, how we are going to follow them up. That is one flowchart you guys have to remember. And the second is colposcopy results, how to interpret the colposcopy results. That's the second flowchart you guys have to remember. The third flowchart is after the colposcopy abnormal results, like you have CIN 1, 2, 3 CGIN, how we are going to go about it. And the fourth thing you have to remember is that if CGIN is there, it's completely excised and it is incompletely excised, how we are going to go about it. These 4 stuff, first you remember, master these things. You yourself put it into like scenarios and try to create that complex, the synapses in your brain itself. And then once you master all of this, you can go for these. Okay, even though it is simple, I don't want you guys to get confused. And waiting policies is very, very easy. High grade, 2 weeks pathway. In your suspecting invasion, 2 weeks pathway. You're suspecting some cervical glandular neoplasia, then 2 weeks pathway. But otherwise, rest all will fall under 6 weeks wait policy. Okay, clear everyone? What is the follow-up after re-excision of CGIN? Similar. So look at the results. So if they say it is complete, the margins are clear, then she will come under how you manage it as completely excised CGIN, which is 2 test of cures. One is at 6 months, another one is at 18 months or 12 months after the previous HPV testing. Okay? Tanya, I forgot your name. Clear?
Clear.
Okay.
Yes, ma'am.
So anything you want to add or ask? I will take your Q&As for next 5 minutes. If any questions, you can ask me. Yeah? No questions? Understood at least what we have discussed so far?
Yes, ma'am.
So any questions from anyone?